I think I have half my patients are class 3s. So I don't have many good friends because when my friends are class 3s also they send it to me right now. So I have about 10 clinics which are within 1 kilometer of my practice. So I get impacted canines, I get perio problems with class 3s. So I do get a lot of class 3 patients. So I have been working with class 3 patients for a long time. So again, this patient came in again looking to correct his smile. So you can again have a look and see that the patient has a negative overjet. He has an anterior crossbite. Whenever you have an anterior crossbite, you will always see the lips don't have support. Whether it's the upper lip or the lower lip, they will always look not supported. So we have to correct the incisor proclamations. This was just his intraoral records. Again, you will see a little bit of a vertical problem here. So if you look at his face here, again you will see a very slight cant here. He has a slight vertical problem as well, which is again because of his occlusion. So if you look at his bite on the right side, you have a crossbite on the entire right segment. But if you look at the left side, you have slightly over extruded posteriors. So again, we have to level both the upper and the lower arch, flatten the occlusal plane, and we try to get the molars and the canines back to their normal position. So he also has a shift. So again, these are the keys I keep reinforcing again and again. We have bite turbos for disocclusion of the anteriors. We have inter-arch elastics to bring the lower arch back to a more normal position. We carry out a little bit of transverse expansion and leveling so that we can correct the crossbites. And at the end of treatment, we need very good settling so that we can stabilize all the changes we have carried out. So again, just disocclusion should give you a lot of correction. So you will see that once your arches start to level, again sometimes the midline shifts are just because of the contacts. So when you when you carry out proper leveling, you will see that the mandible again starts to go to its normal position. So at this point, we just have to keep moving towards bigger wires and we try to finish in stable occlusion. So these are again his mid-treatment pictures. Once you get into a positive overjet, you can see he has a much better smile line, much better incisor display. So we just have to carry out and get better dog expression, and we finish with proper again class 1 canines, class 1 molars, and proper overjet and overbite. And again, you can see that we've removed the third molars. So the benefit of having the third molars removed is getting your molars into a much better improved position. So we just wanted uprighting of the lower segments so that we can use the class 3 elastics to their maximum benefits. And this is his post-treatment set. So you can again see, once we use elastics judicially, even with expansion, ideally we should not get proclamation. We try to finish with as stable a position for the lower incisors as we can. And you can compare history as well as post-treatment self. So you can see now we have a much better support for the upper lip, much better support for the lower lip, and we have a flat occlusal plane, which is what we desire in terms of stability for a class 3 case. So again, we focus a lot in terms of not only correcting the patient's problem, but also looking at what we can make more stable in the long run. Because you will go to a lot of conferences, events where they tell you you should go in for lifetime, nighttime retainers. That is because of movements which are exaggerated. But if we just look at the cause and effect relationship, we try to correct everything just using basics, you will see it is very stable in the long run. And this is his pre to mid treatment and post treatment smile line. So you can see the patient looks aesthetically, and he has a much nicer smile. And this is a comparison of his pre-treatment as well as post-treatment smiles. So I thought I was showing you some mild to moderate cases. I thought I'll show you some more variations of the impacted canines. So I think we still have a few more cases to go. I'll try and see if we can show you more. So again, we had a patient who came in with a vertical problem. So patient has an anterior crossbite. You can see his point B is ahead. In this patient, you can also see on the left maxillary segment there is a missing canine. So his canine was palatably impacted and then he had a grossly decayed second premolar. So what we decided was to remove the grossly decayed second premolar. We wanted to distalize the first premolar and try and gain space with a little bit of expansion for the canine. So I normally try to raise bites as much as I want to, as long as it helps me jump the bite. Otherwise, I would just keep gradually leveling and then jump the bite at a later stage. So a few more months of leveling, you can see now the arches start to flatten, so it starts to look better. And when you see the arch look better on the right side, you will already start to see much more improvement in the canine and molar relationships. Then, this is the journey which I'll show you in clinical pictures for the palatally impacted canine. So, this is just to show you that there was a palatally impacted canine which we were trying to bring out. So initially, this was published as a case report some time back. I published this in, it was a modification of a Kilroy spring. Normally for a Kilroy spring, you have to, either you can buy it commercially, we have lots of options like an isoglide, or you have to use auxiliary wires. We decided to just bend and make our own spring, so which is what we developed. So we again developed a spring. This was our own design from our faculty. So we designed this with a triple helix so that we could turn this into a spring design which would just quickly bring the canine out into occlusion. The reason why it's on a single wire is when you try to compress this, it will work two ways. One, you will see some angulations below the helix. So it tries to make sure that your lateral and your premolars cannot dip easily. But it also works like a spring so that when you keep on pressing it will try to gradually bring down your canines. So it helps you maintain that space, so you don't need to use open coil springs. It will help you maintain space and bring out the canine. So some more months we were able to see the canine in the arch. So at this point we just decided to go ahead with couple mechanics, so that we can derotate the canine and get it into a better occlusion. On the right side you can see we already have class 1 occlusion. Then after derotation you can see now we just have to settle the occlusion and finish. So this is just how the canine went from being placed in the palate to being for the space opening up for the canine, the disimpaction loop for the canine, and gradually bring it into occlusion. So this is just a GIF that we created just to show the canine coming into occlusion. And then you can see, once you get into a proper overjet, you will always see the patient's soft tissue profile looks better. You have more lip support for the upper and the lower lips. So again, whenever you have severe class 3s, you always have a preference. Whenever you level the curve of speed, you will always see much better occlusion and the severity become much lesser. So to show you another example again, we have another patient whose soft tissue profile actually didn't look that bad, but he had an anterior crossbite and as you can see a deep coloscopy again. So we were again left with a challenge on how to treat him. So you can see how this is his
và
self.
đây là cái hình
So
cephalorhynch.
again, when we look at
Và
his
khi
self, we
chúng ta
are
nhìn vào
figuring
cái
out
này,
what
chúng ta
would be the
dùng
best
là
option
đây
to
là,
get him into a positive
và như
overjet.
vậy á, là có
So
rất
we
khó để
decided
cho
once
cây
we analyze this,
và
the
chúng ta phân
extraction
tích ra
index
và
still
cái
says
chỉ số
non-extraction.
cây
So
nhổ
we
răng
thought
á,
of again
và
removing
như
his
vậy
aids
chúng ta
to
có
try and get
thể
him into
là
a
để
proper
nhổ răng
occlusion.
để chúng ta có thể
So
dựa vào
again,
cái
we
cơ
just
cắn
carried out this occlusion.
và cái
I normally
và
don't
chúng
rely
tôi
so much
không
on
có
patients to
trong
use spike plates
là
because they
dùng
tend
cái
not to
pipe
wear
lên,
them.
bởi
So
vì
I
họ
would
không
just
có
go
mang.
with this option
Chúng tôi sẽ cho họ đeo cái
and
răng
just
khớp
go
cắn cố
in
định
with
trong
this
dùng cái
occlusion
pipe
and a
lên.
very small
Và
wire.
ở đây chúng ta thấy
And we keep
và
reducing
chúng ta
the
sẽ
turbos.
giảm cái pitapo đó tiếp tục.
Another 3 months
Và
we
trong
get
ba
the
tháng
patient
chúng ta
into
đã đưa
positive
bệnh nhân
overjet, so we
có
just have to
overset
start to level and align.
và cái làm thẳng hàng răng.
On another 4
Và
months,
4
you
tháng
can
nữa.
start to see on the right
Và
side
chúng
the
ta thấy ở
occlusion
bên này
settle
là
more.
cái
So now we're just waiting
và
for
như
the
vậy chúng ta
other
sẽ
side.
chờ.
Then
Rồi
another 4 months
và
on the 16,
chúng ta
25.
thấy 16
So you can see the bite settling
chúng ta có
down
thể thấy cái khớp
on the
nó
right
sẽ
side.
khớp
We
xuống.
still have more work to do on
Đó
the
là
left
phải
side.
cái
But you see, this is how much
và như vậy
of just
thì
uprighting effect we have. So when you, it's not just expansion
nó không
alone.
phải chỉ là vấn
When
đề
you see
nới rộng.
proper arch alignment, when you see uprighting, when
bạn
you
thấy
see
dựng
proper
trục
dentalaryngeal
và có nhiều
expansion,
cái sự
you
mà
should still
nới rộng ra
look
xem.
at the bone,
Ta
always
xem thử
see,
luôn
look
luôn là
for
xem
fenestrations
cái
there, since you should always
để
see
coi
whether
thử
the
có
bone looks healthy
fenestration
or
không, nó
not.
có bị là đâm cái răng đó ra chỗ
This
răng
is
ra
the
ngoài,
lower
là
arch.
nảy xương hay không, hàm dưới như thế
And
này.
you can see he again gets a much better smile line
Có nụ cười nó đẹp hơn.
and a
Và
much better
cái
profile.
profile
So
nó
again, most
một
times
phần
our
nữa thì
idea
họ
is
sẽ
to try and
chúng ta
correct the
cố gắng
soft
chỉnh
tissue
cái
mass
mô
of
mềm
the
á.
patient by trying to
Và
bring
chúng
the
ta sẽ có
incisors
mang
into a
cái
better position.
và ở cái vị
And
trí
you
tốt
can
hơn.
again see we still didn't manage to procline the anteriors. So you can see we have a very stable position for the incisors. It's a simple protocol that we developed which gives you space to level the arch using some of the dentoalveolar expansion protocols we have. So you can get simultaneous correction, which means again if you look at the images, we are just carrying out leveling. We haven't started using elastics. When you correct the vertical problems, you will automatically start to see the mandible go to a better position.
Ở vị trí tốt hơn, tức là xoay mở cái hàm dưới gì tăng kích thước chọc xoay mở hàm dưới thôi.
Then we have, I'll show you another variant, not a class 1 slide. So this is again a class case with class 3 canines, class 3 molars. This was more of a dental class 3 problem with a Bimax profile. So the patient was looking for a profile change, but her profile was
Bệnh
very
nhân á,
convex.
là có cái mặt
So
lồi,
whenever
thay
the
đổi
patient
khuôn mặt.
has crowding, proclination, profile correction, we always think in terms of
Ta sẽ nghĩ đến
extractions.
phải nhổ răng. Răng á,
So
thì
this
hàm
was
ba,
her pre-treatment self.
khuôn mặt
So
rồi.
you can see that her
Các bạn
upper and
thấy
lower
răng
incisors are
trong răng
proclined.
hàm dưới đều
She
như
was
bình
already high angle,
Và bệnh
so
nhân
this
có
was
cái,
just
góc
complicating
cao.
things for us a
Đây
little bit.
là một những yếu tố
So we
phức tạp.
decided to
Ta
extract her
sẽ
upper and lower
nhổ
teeth.
hàm trên hàm dưới.
The major problem with this patient was that she only had about 16 months of treatment time, and she was looking to move to the US.
Và sau
So
đó sẽ
we
đi Mỹ.
essentially
Cho
had to
nên
finish
đặt
her
cho chúng ta
treatment at
kỳ hạn
space
là phải làm
closure.
sao phải đóng khoảng cho
So
nhanh
which is
17
why
tháng
for
cho
the
sau.
lower arch we started
Chúng ta sẽ
canine
bắt đầu
retraction
là kéo
and
răng nanh
used closing loops.
và dùng cái
For
closing
the
loop.
upper arch, we
Hàm
decided
trên
to
chúng
use
tôi
a
sẽ quyết
combination
định
of
là dùng
closed closing loops
cái
and
nút mà
keyhole
đóng
loops
và
that we
keyhole
would
nút.
activate
Và
at
chúng ta
the
sẽ
same
bật
time so that
đồng
we
thời
could move, distalize the canine and
và
have
vista
enough
răng nanh
cord
và
control
chúng ta
to
có
retract
cái
the
độ cong
anteriors.
ở những cái
So
răng
we
trước.
wanted enough
Chúng ta
control
có
over
thêm
both
được
the
kiểm
anteriors
soát
as
cả
well as
các
the
cái răng
canines.
nanh và răng trước luôn.
So we managed to
Và
close
chúng tôi
space.
đã
This
có
is
thể
roughly
đóng
at
lại
about
cái
the
khoảng
1 year period
một
when
năm là
we
chúng ta
close
đóng được cái
spaces.
khoảng.
Now we have class
Và
1
bây giờ chúng ta
molars,
có
class 1
tương quan răng
canines.
cối hàm một,
She
tương
also
quan răng
has
răng hàm một.
multiple decays
Vậy bệnh nhân có
at
nhiều cái răng
anteriors.
phía
She
sau ở
also
phía trước.
had PMMAs
Và
which we
bệnh
had
nhân
to
có
fix.
cái PFMA là để
And
cái
finally, we were able to
những
finish up with
PFMA
class
để
1
chúng ta có thể
canines,
là
class
đóng lại.
occlusion plane,
Và
and class 1
và
molars.
đây là chúng ta có hàm một răng nanh, hàm một răng cối.
This was a pre and
Đây
post
là trước
spine,
cái điều trị.
and this is a pre and
Đây
post
là cái
set.
trước
So
và
again, we
sau
tried
của
to get the
set.
incisors in as stable a
Và
position as possible. She was already
và
high
bệnh
angle,
nhân
so
có
we tried
cái
to just
cốc cao
maintain and not
và
increase it
chúng ta
more.
không có tăng thêm.
And this is a composite
Đây
emission
là cái
power
composite.
entire treatment.
Toàn bộ cái điều trị.
So again, I thought I would show you some of the complex
có
cases that we handle.
những cái
Maybe one or two
và
cases.
một trong những
Is
cái
that okay,
ca
or do you want me to
và
finish?
các bạn bây
Or
giờ
is
là
okay?